Thank you. Hello again. Yes, the big London. The London where we have 3,000 gay men coming to our clinic each month who use chems or drugs, recreational drugs for sex. Not a single one of them identifying as an addict. Not a single one of them identifying a drug problem. Not a single one of them coming asking for help with their drug use. They're coming with the consequences of their drug use, which is repeated gonorrhea infections, HIV infections, syphilis and gonorrhea, and they're presenting for help with those consequences of the drug use, but they're not seeking help with it. But it does provide us with an incredible opportunity to do some behavioural interventions at that point to see if they're enjoying their sex lives and how can we reduce all of those risks. Perhaps, I'll get to that in a minute. I think chemsex or party and play, P&P culture, might need a little bit of definition. I think heroin and crack cocaine we're very familiar with as the addiction model. I think if you want to, heroin and crack cocaine serve very distinct purposes. You don't do those drugs to go out and have a laugh. You don't do those drugs to have some fun or have a great shag. Do we use shag in this country? To have sex. They serve a very distinct purpose, and gay men traditionally have not really warmed to those drugs very much. In fact, where I come from in the UK, less than 2% of gay men have preferred heroin or crack cocaine. They've preferred party drugs, things like ecstasy and cocaine and MDMA. And the stereotype would not be that drug addict that you might associate with a heroin or cocaine user, heroin or crack cocaine user. It would be the guy on the dance floor with his shirt off, connecting with his community, dancing, having a good time, maybe having sex. And throughout the, 80s, 90s and early 2000s, gay men were using a lot of ecstasy, a lot of cocaine and a lot of alcohol, of course, and a lot of MDMA and ecstasy, if I didn't say that already. And they were using it in sexual contexts too. Believe me, they were. Some evidence that we have suggests that gay men use 10 times more recreational drugs than their heterosexual counterparts. What we didn't see in the 80s, 90s and early 2000s were gay men rushing to A&E emergency departments with overdoses or with psychosis symptoms. We didn't see gay men rushing to addiction services looking for needles to inject their ecstasy, or we didn't see gay men rushing to addiction services saying, "Help me, I'm addicted to ecstasy." We didn't see particularly large numbers of sexually transmitted infections or HIV infections, particularly attributable to those drugs. But something was changing in the early 2000s. It was technology. I spoke yesterday about Grindr and other geosexual networking apps and how they completely changed the way gay men hook up, seek and find sex and communicate. And that was rocking their world. There was also HIV prevention, I also spoke, was changing yesterday. HIV care was getting better, but the HIV prevention tools and knowledge we asked our gay men to take into their bedrooms with them was getting more complicated. And of course, these new drugs were overtaking it. GHB, GBL, crystal methamphetamine, one that you don't have here yet, I think, which is mephedrone. Keep your eye out for it. Raise your hand if anybody has come across anyone. Yes? Of course, from the drug service. Okay. These are the drugs which are different from ecstasy, and when those new drugs started becoming much more available, very quickly available, to a population, partly because of the geosexual networking apps, which were allowing people to find drugs faster and share them faster, suddenly we did see large numbers of gay men going to emergency departments with overdoses, with withdrawal symptoms, with psychotic episodes of psychosis. And we saw larger gay men going to addiction services to an extent, with looking for needles to inject these drugs and with addiction problems. And we did see larger numbers of sexually transmitted infections, including HIV and Hep C, and I'm talking about sexually transmitted hepatitis C, as a result of these new drugs. And that was what came to be defined as this kind of a new syndemic of behaviours and circumstances called chemsex or P&P culture, party and play. And it's very different, and it's changing the way we have to address things. Let me give you an example. I mean, when I first came to work at 50 Dean Street, I was working in a drug service, a heroin service, and I went to 50 Dean Street in 2010 on a Thursday, and I asked if they had heard of chemsex or P&P. They said, yeah, we think we've got it under control, though. We did notice that a lot more of our gay men are using those drugs you mentioned. And we thought, okay, well, I'm glad to hear that. Can we form a relationship and see if we can, make sure that we're looking after our patients? I popped back 3 days later after it happened to be a bank holiday, Easter weekend, on the Tuesday after that, and I hung around the PEP clinic. We have about 30 people show up for PEP each day at 5016 Street. And I asked the nurses to ask questions differently. The questions had been previously, do you use illicit drugs? Are you an injecting drug user? Or have you had sex with an injecting drug user? Which in a sexual health setting, they're good indicators of risk of bloodborne viruses and things. I asked the nurses to ask questions differently this day. Do you use party drugs for sex? They had to do it with a big smile on their face. Do you use party drugs for sex? What's your favourite one? And are you having a good time? Those 3 questions. I'm going to repeat them because I want them to sink into your brains. Do you use party drugs for sex? Are you having a good time? What's your favourite one? And on this day, our patients responded very differently than they had to the typical questions. Now, 33 gay men showed up for PEP on that day, and every single one had responded positively to those questions. They'd come from a chemsex, party and play kind of environment. And yet 3 days earlier, we thought we'd had it under control. We didn't think it was that big of a problem. The point being, it was happening right under our noses and we didn't even know it. We could go to sexual health clinics and say, it's not, and they would tell us, it's not really a big problem here. We don't have people walking into our clinic saying, help me with my chemsex, help me with my PNP culture problem. It wasn't happening. They were just coming with the consequences. And so it was about asking the questions differently. I'm going to give you another anecdote then, because in the drug service I used to work in, imagine a drug service, a typical drug service, if you will, an addiction service. 2 men are sitting in the waiting room. One, I'm going to do stereotypes, forgive me, is a heterosexual heroin injector or methamphetamine injector. Street homeless, perhaps, probably HIV negative, probably Hep C positive, possibly sharing needles. And in that drug service, he's going to tick every high-risk box. He's possibly transmitting hepatitis C through the sharing of needles. The burden to society from the homelessness and any addiction problems that might be going along, it might cost thousands of dollars a year to keep this person engaged in care. Sitting next to him is a gay man, and he's not injecting any drugs at all. In fact, he's only using recreational drugs. He owns his own home, he's got a boyfriend, got a job. He's only doing these drugs twice a month. And he's not going to tick a lot of high-risk boxes. Now, drug services are amazing. They will do a behavioural intervention and support this person to make changes if they wanted. That's what they do, and help reduce the harm. But if he was sitting in front of someone in a sexual health or testing setting, we're going to be asking how many partners is this person having when he uses those recreational drugs. It might be between 5 and 15 partners per one drug-using episode. What's the likelihood of him using condoms when he's under the grip of these very powerful highs that these drugs are giving him? And they're probably, if they're anything like our data, very low likelihood that he's going to be using condoms. He wants to when he's sober and having sex on Wednesday off drugs, but under the grip of these drugs, very unlikely to be using drugs. Remember, a city which has a high prevalence of HIV, a lot of, perhaps 20% of which in my city is undiagnosed. The chance of this young man sitting in the drug service catching HIV within the next 3 to 6 months is very, very, very high. And before we could test him and get him on treatment and undetectable, and perhaps offer some behaviour change therapies to change his behaviour, he's going to become infected and infect many others. And that's going to cost, if we consider onward transmissions, millions of dollars a year in onward transmissions and care for that person. And yet he wasn't ticking a lot of high-risk boxes in that setting. The point I'm making is that if we're talking about chemsex and PNP, and there's a very different kind of drug problem, which is becoming big. It was huge in San Francisco some years ago, New York, Los Angeles, Melbourne. I've just come from Vancouver, where they're experiencing it there, Sydney and Melbourne. London's got it big, and many cities throughout Europe. And I've been speaking to my colleagues the last few days, and it's here. I'm wondering if it's very much under your noses and what you are doing, or what you can do to sort of support these gay men. I'm full of anecdotes, I'm sorry. I was also in Los Angeles for a screening of the chemsex documentary in a 700-seater auditorium. And I'd been visiting the health services in Los Angeles, and they had been saying, yes, it's not that big a problem here. In fact, we don't have that particular drug in our city. And we asked the 700 people coming, gay men mostly, in that auditorium, how many people had been affected by chemsex, PNP culture. either through their friends or themselves. It was 90% of the hands went up. Completely contrary to what I've been hearing from the health services. And on the panel afterwards, there was an extraordinary psychologist from a methamphetamine addiction service who spoke brilliantly about how her service was LGBT efficient and aware. And next to her was a young gay man who had exited drug addiction. He'd been a methamphetamine injecting drug user that had got support from their addiction services. And they were saying to the audience, please, we are LGBT aware at our addiction service. Please know that we are here to support you. And I was getting a little frustrated. I had to put my hand up and I said, have I come all the way from London just for you to tell me that you've got this problem sorted? Because out there in this 700-seater auditorium, there might be, I don't know, I'm going to guess 60 to 100 perhaps, of guys that are engaging in chemsex, PNP play. They're not injecting drugs. They're only drinking G, which a lot of the services hadn't heard of, smoking crystal meth perhaps, engaging in what we would call very high-risk sex. And a lot of them are going to catch gonorrhea 4, 5, 6, 7 times this year. And a lot of them are going to become HIV positive before the end of the year as well. Now, do we sit in the addiction services waiting for them to identify that there's a problem and access support while they are coming to our testing services and our HIV clinics and we're not asking the right questions the right way? It's early days in Toronto, in Canada, for chemsex and PNP. It might not become a problem, but we left it too late. And I hope that I'm here early enough. I think what I'm doing, I haven't been looking at you, how much time I've got left.
You have about 3.5
Thank you. I'm blind in my right eye, so I have no idea that you're there. Make a lot of noise about it. So I think what I'm inviting you to do is talk to each other. This is a difficult kind of new problem. It's challenging all of us. The drug services don't have all the information. They don't do their screening questions. They don't know if that person sitting in the waiting room, if he had had sex in the last 3 days that might have exposed him to HIV. They don't know how to do a PEP assessment. They wouldn't offer PEP there. In some of our services we do. Chemsex, PNP support has to be done in our services with help from the drug services who know how to do behavioural interventions around addiction. They know how to dispense needles and talk about safer needle use. But really we need to be identifying it because we've got patients that are catching, transmitting HIV, perhaps not taking their antiretrovirals if they are already HIV positive. People who are becoming infected with HIV in a big way because of what we might call an addiction problem, but these guys are calling a sex problem, something associated with gay sex, with Grindr, with loneliness, with isolation, with modern gay trends, with hooking up culture, with peer pressure, with shame around sex, with HIV stigma, complicated communication skills, inabilities to form intimacies and relationships. I don't know the right place for that support to happen, but we decided that it was in our testing centre. We decided that we would get some gay men from the gay charity who knew what it's like to be lonely and horny on a Saturday night with an app on the phone and how to talk to someone about that. We got someone from the addiction service who knows about withdrawal symptoms, addiction and behavioural interventions. And it was happening in our setting where we had all of the risk assessments required to check, to keep people HIV negative and to capture people before they were identified that this might be a problematic, epidemiologically problematic and personally problematic problem for them. So the buck stops somewhere. There is no amazing chemsex school in the sky. Did you gesture to me just then? Is there an amazing chemsex school in the sky that you go and learn how to do chemsex support? It doesn't exist. There was a time in the 80s when there was someone dying very ill with AIDS, and there was a doctor who did not know how to deal with it. It was not in his textbook. Maybe he passed the buck on to someone else. Maybe passed it on to someone else. Maybe at some point somebody just stopped and said, I don't know how to deal with this. I'm just going to have to make it up as I go. I'm going to help you. Chemsex, I'm not comparing it to AIDS, but it does require a little bit of thinking because you cannot go and learn how to do chemsex. I think there are people sitting in front of you, and if you ask the questions the right way, do you use party drugs for sex? What's your favourite one? Are you having a good time? Just asking the right questions and opening a dialogue We don't have to have the answers, but quite often our patients have the answers. It's just about reflecting and having someone ask them the right questions and listen and talk to them about experience they're saying. You don't have to have the answers. You just have to be able to contact the right people that do and talk to our patients, because they just need someone to talk to us about their lifestyle problems, and it's our job to keep them safe from infections. I'd like to tell you a whole lot more, but I have a website. I haven't used any of my slides, but these slides that I haven't used are available for you, where there are links and video tutorials and suggestions on how you can get a response going in Ontario. Thank you.